How can two patients undergo identical cataract surgery performed by the exact same surgeon on the very same day, yet walk away with completely different lifelong vision experiences? One leaves absolutely overjoyed. The other spends the next 2 decades quietly dissatisfied. Do not fixate on the surgeon's steady hands, the precision laser equipment, or the hospital's glowing 5-star Google reviews. Instead, focus on a 90-minute consultation that happens weeks before either patient ever steps into the operating room. A quick discussion most patients barely remember having at all. Here is the unspoken truth almost no one shares with you upfront. The highest risk part of cataract treatment is not the surgery itself. Cataract removal is one of the safest, most refined, and most consistently successful procedures in modern medicine. The real critical risk comes down to one choice you make while sitting in an exam chair, often in under 2 minutes, and far too often without fully understanding what you are agreeing to. Once this decision is made, it is permanent. There is no return policy. There is no simple swap a year later because you changed your mind. You live with this one decision every waking moment for the rest of your life. Every sunrise you look at, every road sign you read while driving, every face across your dinner table, every phone screen you scroll through late at night. The vast majority of patients get this choice wrong, not because they are careless or unintelligent, but because they never realize they are making a life-altering decision in the first place. Hello, over decades in practice, I have sat across from thousands of patients in that exact exam chair, and I have watched the same pattern unfold again and again. Patients spend weeks researching surgeons. They scroll through online reviews. They ask friends and neighbors for recommendations. They stress endlessly over the surgical procedure itself. The 10-minute operation they will barely feel while sedated. Then they arrive at the consultation completely unprepared for the single most important decision of the entire treatment journey. The choice that determines how clearly they will see the world for the rest of their lives. They let this vital decision get settled in a rushed conversation they do not know how to guide. Some patients are pushed toward expensive premium lenses that are fundamentally mismatched to their eye anatomy. Others never even learn all the lens options available to them. Either way, they discover the regret far too late. In this video, I will break down exactly what this pivotal decision involves. I will explain why its impact is so massive, and I will give you a simple framework that separates patients who walk away delighted from those who spend years wishing they could reverse their lens selection. I will walk you through the 3 core categories of artificial eye lenses. I will unpack the hidden compromises built into every single type. I will expose the nighttime driving trap that affects countless patients who choose premium lenses for the wrong reasons. I will also explain how underlying eye conditions can automatically rule out certain lens styles. That is a critical detail many providers fail to mention clearly. I will cover the practical monovision strategy, and I will show you a simple pre-surgery test you can complete to find out whether this method will work well for your eyes. I will also share specific direct questions to ask your surgeon. That way, you enter your consultation fully informed instead of being persuaded into a lens option that is not right for you. Before we dive into all these details, I have a quick small favor. Viewers message me constantly saying they have watched several of my educational videos but never subscribed to the channel. Could you take 2 quick seconds to hit the subscribe button right now? Subscribing costs absolutely nothing, and it helps this channel share straightforward, unfiltered medical guidance with more people who desperately need this knowledge before they lock in irreversible medical choices. Thank you so much. Now let us start by breaking down how your eye works, because understanding this basic anatomy makes the entire lens decision crystal clear. Think of your eye's natural lens like the lens inside a digital camera. It sits directly behind your colored iris. Its job is to bend light so that it lands sharply on the back wall of your eye, producing crisp, clear vision. When you are young, this natural lens is transparent and flexible. As decades pass, proteins inside the lens gradually clump together. The lens becomes cloudy and yellowed, much like a foggy brown stained window pane. That clouding is what a cataract is. Colors lose their vibrancy. Oncoming headlights blur into spiky halos at night. Small text becomes harder to read, and the whole world dims around you so slowly that many people do not realize how much vision they have lost until surgery restores it. Cataract surgery corrects this problem with a remarkably simple and sophisticated technique. Your surgeon creates a tiny micro-incision on the surface of the eye. Then the cloudy natural lens is gently broken apart and removed. After that, a brand new artificial lens is placed into the exact space where your original lens used to sit. This artificial implant is called an intraocular lens, shortened to OL. It is a tiny, clear disc smaller than the fingernail on your pinky finger, and it remains permanently positioned inside your eye for life. This brings us to the core message of this video, and I want you to absorb this fully. The natural lens you are born with can shift focus automatically. It flexes smoothly so you can look at a distant mountain range, then instantly shift your gaze down to a book without extra effort. Most artificial replacement lenses do not have that same flexibility. They have a fixed focal power that is locked in by your surgeon during implantation. So when you choose your intraocular lens, you are not simply choosing a small piece of plastic to place inside your eye. You are permanently defining the distances your eyes will see sharply and the distances where you will need corrective eyewear. This is the life-changing decision we have been talking about, and it only gets made once. Let us break down the three primary lens categories, each with its own trade-offs that most patients never expect. The first category is monofocal lenses. These are the standard workhorse implants used in cataract surgeries around the world. The prefix mono means single, and that perfectly describes how these lenses work. They deliver one single crisp focal distance. Surgeons almost always set these lenses for clear distance vision. After surgery, you will usually see roads, television screens, faces across a room, and trees outdoors clearly without glasses. The clear and predictable compromise is simple. You will need over-the-counter reading glasses for close-range tasks. Reading books, restaurant menus, smartphone screens, threading needles. That is the full trade-off. Monofocal lenses deliver outstanding image clarity with minimal unwanted side effects. And basic insurance or public healthcare systems cover this lens type in most regions. The deal is straightforward. Sharp distance vision, affordable drugstore reading glasses for close work. The second lens category is where most patient dissatisfaction begins. Multifocal and trifocal premium lenses. These are the implants featured in glossy marketing brochures. They are marketed with an incredibly tempting promise. Multiple focal zones are built directly into the lens disc. Incoming light is split to serve far, intermediate, and near vision at the same time. The sales pitch promises freedom from glasses, reading your phone, driving long distances, working at a computer, all without reaching for reading glasses or distance glasses. And for many patients who choose these lenses, that promise is real. But brochures rarely emphasize the hidden downside. Because these implants split light across several focal points instead of sending it through one clear path, your brain has to sort through overlapping layered images. Two common side effects can follow from this light splitting. First, visual contrast can soften. The sharp boundary between dark and light areas becomes less crisp. This is especially noticeable in dim lighting. Second, and far more disruptive for many patients, artificial light sources can create halos, glare, and starburst flares at night. Street lights develop glowing rings. Headlights from oncoming traffic flare wildly. The moon may appear surrounded by a hazy glow. For some patients, these visual distortions fade as the brain adapts over several months. But for a notable group, they never fully disappear. These premium lenses can also carry thousands of dollars in out-of-pocket costs per eye. They are usually classified as an elective upgrade not covered by standard insurance. So, the trade-off is this lifelong freedom from corrective glasses for many tasks in exchange for significant personal expense and a permanent risk of compromised nighttime vision. The third category is more of a balanced middle ground, and it includes two practical approaches. The first option is extended depth of focus lenses, commonly shortened to EDOF lenses. Instead of creating separate segmented focal zones like multifocal lenses, EDOF technology stretches one focal point into a longer continuous range of vision. This can deliver sharp distance vision plus clear intermediate vision that is excellent for driving and computer screens, and it usually produces fewer nighttime halos than trifocal alternatives. The minor compromise is that very small close-up reading tasks may still require light reading glasses. This lens can be ideal for patients who want to reduce dependence on glasses without accepting severe nighttime visual disturbances. The second balance strategy does not require a specialized premium lens at all. It is known as monovision, and it can be an extremely effective vision adjustment method. Surgeons use standard monofocal lenses but set one eye for sharp distance vision and the other eye for close-up reading vision. Your brain automatically switches between the two eyes based on what you are looking at. No conscious thought required. Patients who adapt well to monovision can often reduce or eliminate glasses while enjoying the sharp, clean visual quality of simple single-focus implants. The main limitation is that not every brain comfortably processes two eyes set to different focal lengths. Some patients report weaker depth perception or distracting blur during nighttime driving. The biggest advantage, which we will come back to later, is that you can test how your brain tolerates monovision long before committing to permanent surgery. One often overlooked detail that can ruin otherwise successful cataract results is astigmatism. Astigmatism means your eye curves more like an oval rugby ball than a perfectly round sphere. That uneven curve creates blur across all vision distances. If significant astigmatism remains uncorrected during surgery, even the most expensive premium lens can leave you constantly reaching for glasses. The solution is a toric version of whichever lens you choose. A toric lens is specially designed to counteract the uneven curvature of the eye. Skipping toric correction is one of the top reasons patients feel disappointed after otherwise flawless cataract procedures. Now that we have covered the lens trade-offs, let us review what clinical research consistently confirms. First, cataract surgery itself is extremely effective. It is one of the most commonly performed surgical procedures in the world. Tens of millions are completed every year, and the overwhelming majority of patients across lens types report improved vision and overall satisfaction. This video is not designed to scare you about the surgery. The operation itself is a modern medical success story. This video exists to help you maximize your final vision outcome. The second critical research finding compares multifocal lenses with standard monofocal implants, and the pattern is very consistent. Patients with multifocal lenses are more likely to go without glasses for everyday activities. That fulfills the core marketing promise. But those same patients also report stronger halos, more glare, more nighttime driving difficulty, and measurable contrast reduction compared with monofocal lens recipients. This is not baseless fear-mongering. It is predictable optical physics from splitting light across multiple focal planes, and it has been shown repeatedly across clinical studies. Third, research identifies a small subset of patients who experience severe long-term regret after choosing multifocal lenses. Most users adapt and remain happy, but a notable minority deal with persistent nighttime visual disturbances severe enough to require a second surgery to remove and replace the premium lens. That second procedure is far more complex than the original cataract removal. The key detail is this: many patients in this dissatisfied group had pre-existing eye conditions that should have made multifocal implants a poor fit from the start. This leads to the fourth and most widely ignored research takeaway. Coexisting eye conditions completely change which lens will work best for you. Clinical data confirms that patients with specific secondary eye health issues rarely achieve good results with multifocal lenses. Macular degeneration, glaucoma with optic nerve damage, diabetic retinopathy, chronic severe dry eye, irregular corneal tissue from prior LASIK. These conditions already reduce natural light sensitivity and visual contrast. Multifocal lenses can make those limitations worse by splitting incoming light and stacking multiple visual deficits on top of one another. For these patients, simple monocal lenses almost always deliver cleaner, sharper, long-term vision. Unfortunately, some providers recommend costly premium lenses without walking patients through how their existing eye conditions can change lens performance. And this mismatch accounts for countless dissatisfied patients I meet every year. The fifth hopeful research discovery centers on monovision compatibility. Your ability to adapt to this vision style is highly predictable. Studies show that simulating monovision beforehand with trial contact lenses can accurately predict how well your brain may adapt to permanent surgical monovision. One contact lens is calibrated for distance, the other is calibrated for close vision. You wear them consistently for about 2 weeks. In other words, you can test drive your future vision before locking in an irreversible surgical choice. That is a luxury no other lens selection method offers in quite the same way. I want to share a simple decision framework I wish every patient brought into the consultation. Ignore glossy marketing brochures. Discard the idea that one single lens works for everyone. There is no one-size-fits-all best lens. There is only the best implant for your unique eye structure and daily lifestyle. Answer these 5 honest personal questions to narrow down your best lens match. Question 1. How often do you drive after dark? If nighttime driving is a regular necessity, especially for work commutes, multifocal lens halos and glare can create real safety concerns and constant irritation. This single lifestyle factor alone pushes many frequent night drivers toward monocal lenses, EDOF implants, or monovision correction. Question 2. What does your daily close-range work routine look like? If you spend hours every day doing detailed near tasks and dream of eliminating reading glasses entirely, the glasses-free benefit of multifocal lenses may become far more valuable. It may even be worth accepting some nighttime vision trade-offs. Question 3. Do you have any secondary eye health conditions? Do not overlook this question. If you have macular damage, glaucoma, diabetic eye changes, persistent severe dry eye, or previous LASIK surgery, you must approach premium multifocal lenses with extreme caution. Have an open and thorough conversation with your surgeon about whether a straightforward monocal lens would deliver more reliable long-term vision. Question 4. What is your realistic budget and how do you feel about wearing corrective glasses? There is no shame whatsoever in choosing monofocal lenses paired with affordable drugstore reading glasses. Millions of people live fully satisfied with this combination every single day. Never allow anyone to pressure you into believing that budget-friendly eyewear is an inferior choice. Often, it is the most logical choice for your needs. Question 5. How adaptable is your visual processing? And are you willing to complete a monovision contact lens trial? If you have flexible vision and want to reduce glasses use, this low-cost 2-week contact lens trial can open the door to nearly glasses-free sight with excellent image quality. Work through these 5 questions honestly. The ideal lens category for your eyes and lifestyle will become much clearer. Next, I will share the insider strategies that separate patients who nail their lens decision from those who leave the consultation confused and regretful. Tip 1. Complete a monovision contact lens trial before settling on any lens option. If you hope to reduce glasses dependence at all, ask your optometrist for trial contacts calibrated for monovision. Wear them through your regular daily routine for 2 full weeks. Drive at night, read books, work at screens, scroll your phone. If your brain adjusts comfortably, you may have found an affordable, high-quality vision solution. If the 2 focal settings cause dizziness, blurriness, or discomfort, you have avoided a permanent surgical mistake for only the small cost of trial contact lenses. Tip 2. If both eyes require cataract surgery, consider staging your procedures. Complete surgery on one eye first, then wait several weeks before operating on the second eye. This lets you fully experience your new vision quality with the first implant before finalizing the lens plan for the remaining eye. If any unexpected visual downsides appear after the first lens choice, you still have a chance to adjust your strategy for the second eye. Tip 3. Push your surgeon to discuss your unique eye measurements and pre-existing conditions instead of making generic blanket statements about lens types. A thorough personalized consultation centers on your specific eye health data. If the conversation feels like a sales pitch pushing one expensive premium implant, regardless of your personal eye limitations, pause the discussion or seek a second opinion. Tip 4. Request a second opinion if your consultation feels rushed or if you feel pressured to commit to a lens immediately. This lens choice is permanent and there is almost never a medical emergency forcing you to make a final decision the same day as your exam. A thoughtful, ethical surgeon will respect your desire to take time, research, and consult another eye specialist. Tip 5. Ask your surgeon the most revealing single question possible. If you had my exact eye measurements, pre-existing conditions, and daily lifestyle, which lens would you choose for your own eyes? Their response, along with how openly they discuss the trade-offs, tells you everything you need to know about whether their recommendation is genuinely personalized to you. Now let us review the recurring costly mistakes I watch patients make year after year. Mistake 1. Treating lens selection as a reversible decision. It is not. Many patients casually agree to whichever lens the provider suggests, assuming they can fix vision issues later. There is no simple corrective procedure that easily swaps out implants after surgery. Always make your lens choice with the understanding that it will shape your vision permanently. Mistake 2. Choosing premium lenses out of vanity or the false assumption that newer technology automatically means better vision. A multifocal implant is not a luxury upgrade like a higher-end vehicle. It is a specialized optical tool with built-in visual compromises. For mismatched eye anatomy or lifestyle needs, the cheaper standard monocal lens can deliver far superior daily vision. A higher price tag never guarantees better sight for your individual eyes. Mistake 3. The most devastating error I encounter is ignoring pre-existing secondary eye conditions. If you have macular degeneration or glaucoma and you agree to a multifocal lens that further dims your already compromised contrast vision, you could spend decades frustrated with your eyesight. Your secondary eye health issues are not minor footnotes. They are the foundation of your entire lens decision. Mistake 4. Overlooking astigmatism correction entirely. If your eye has significant astigmatism and you skip a toric lens option, even a perfectly matched implant may leave your vision blurry across all distances. That can force you to rely on glasses constantly. Always ask your surgeon directly whether you have astigmatism and how they plan to correct it during your operation. Mistake 5. Choosing your surgeon based on flashy marketing ads instead of proven patient outcomes and thorough consultation communication. The most elaborate advertising campaigns and cutting-edge laser technology do not guarantee satisfying long-term vision results. A surgeon who listens carefully, explains every lens trade-off transparently, and customizes recommendations around your unique needs is far more valuable than any polished marketing material. Mistake 6. Remaining silent during your consultation. Patients who walk away satisfied are the ones who ask follow-up questions. They pause to request clearer explanations. They openly share personal lifestyle details such as frequent nighttime driving or a strong dislike of wearing glasses. Consultations can move quickly. It is your responsibility to slow the conversation down until you fully understand every lens trade-off before committing. Here is the core takeaway from all this guidance. Cataract surgery is a true modern medical breakthrough. It can restore bright, sharp, vivid, full-color vision to someone whose world has faded into a dull yellow fog. And it can do this within minutes through minimally invasive surgery. The procedure itself is not something to fear. And while surgical skill certainly matters for a smooth recovery, poor long-term vision satisfaction almost never comes from surgeon error alone. Disappointment nearly always traces back to lens selection, the quick, overlooked permanent choice most patients do not even recognize as the pivotal moment of their treatment journey. Patients who leave surgery thrilled are not always the ones who spent the most money or selected the newest trendy premium lens. They are the patients who understood that a critical lifelong choice was sitting in front of them. They matched their lens selection honestly to their eye anatomy and daily routine. They asked direct, thoughtful questions, and they refused to be rushed into a hasty decision. This single distinction makes all the difference. It costs nothing more than a small amount of advanced preparation, but it rewards you with clear, comfortable vision every single day for the rest of your life. Before your scheduled cataract consultation, work through those 5 core personal questions. Walk into the exam room with a clear understanding of how often you drive at night. Know your close-range work demands. Know your pre-existing eye health conditions. Know your personal budget limits. Know whether you are willing to test monovision correction. Ask your surgeon that vital personal question about which lens they would choose for their own eyes under your exact circumstances. And remember this, the standard monofocal lens, the unadvertised basic implant without glossy marketing materials, leaves countless patients completely satisfied with their vision. Never allow anyone to pressure you into dismissing this simple, effective lens option if it fits your lifestyle and your eyes best. Let us recap the key takeaways we have covered today to lock in this critical information. 1. The defining choice in cataract treatment is not the surgery itself. It is the permanent artificial intraocular lens you select. And most patients never realize how impactful this decision truly is. 2. Monofocal lenses deliver razor-sharp vision at one fixed distance. They require reading glasses for other ranges, but they come with minimal unwanted side effects and the lowest overall cost. 3. Multifocal and trifocal premium lenses can reduce or eliminate glasses use, but they split incoming light, which can trigger persistent halos, glare, and reduce visual contrast. This is especially important for nighttime driving, and these lenses often come with steep out-of-pocket costs. 4. Extended depth of focus lenses and monovision correction can act as balanced middle ground options. They deliver much of the glasses-free convenience of premium lenses with fewer disruptive nighttime visual side effects. 5. Uncorrected astigmatism can ruin otherwise flawless surgical outcomes. So always discuss toric lens correction with your provider during your consultation. 6. Pre-existing eye conditions, including macular degeneration and glaucoma, can make premium multifocal lenses a poor fit for your eyes. So these health conditions must be central to your lens discussion. 7. You can safely trial monovision with disposable contact lenses before committing to permanent surgical correction. 8. Never finalize your lens selection under sales pressure. Seek a second specialist opinion if you feel uncertain. And always ask your surgeon which implant they would personally choose given your eye health and lifestyle. Your eyesight is far too important to settle on a permanent lens during a rushed 2-minute consultation you are unprepared for. You have far more control over your final vision outcome than most medical content leads you to believe. The medical technology behind cataract treatment is incredibly advanced. The surgical process is proven and widely successful, and the variable left to perfect is the one decision entirely within your control: your intraocular lens selection. Make this choice armed with full, clear information. If this video helped you understand cataract lens options, I have 2 quick requests for you. First, share this video with any loved one facing a cataract diagnosis or upcoming eye surgery. This lens knowledge is exactly the kind of information nearly every patient wishes they had learned before the consultation. Yet, too few providers explain these trade-offs openly. Second, subscribe to the channel and hit the like button so this platform can continue delivering straightforward, unbiased medical guidance to the people who need it most. If you want to expand your understanding further, check out my additional videos explaining what cataract surgery feels like from start to finish, and watch the full breakdown on how to choose a trustworthy eye surgeon. The direct links to those videos are displayed on screen right.